The next speaker is Dr. Kriti, Dr. Kriti Joshi. So it's again a pleasure to introduce our young pediatric endocrinologist, Dr. Kriti Joshi, who works in AIIMS Rishikesh. And she has a particular interest in immunopathogenesis of type 1 diabetes. And she has done a good amount of research. Her PhD work was on pluripotent stem cells and their role in beta cell regeneration. So she has her lecture on beta cell regeneration and what is the status at present in type 1 diabetes. Yeah. Dr. Kriti, please.
Thank you so much, sir, for the introduction. I'll just start sharing my screen now. Okay. I hope my slides are visible, sir.
Yeah, so you can make it slideshow, yeah, please.
Yeah, okay. So I'll go ahead then. All right, so at the outset, I'd really like to thank Rakesh sir for the wonderful introduction. And thank you very much for the organizers for inviting me for this CME. So I'm going to talk about this topic, which is very close to my heart, because this is something that part of it is what I've been working in, and the remaining half is what I'm very interested in following, like the rest of us. And it's a really hot topic of research. And as pediatric endocrinologists, I know that we're all not interested just in managing our patients, but also offering them a hope for a potential cure. So this is what I'm going to talk about today as to where we currently are in terms of our strategies for beta cell preservation and therapy. So before we actually go on to the subject, I always find it useful to begin just with revising or going over the stages of diabetes. And I think everyone knows this recent classification that was brought out by the ADA and JDRF in 2015, which talks about the sort of reclassified stages of diabetes. And very importantly, what this classification brought out was that the early stages, or the pre-symptomatic stages of diabetes, where the disease has not yet presented clinically, but the autoimmune process has started with development of autoantibodies and plus minus dysglycemia, is already considered the start of clinical diabetes and the start of autoimmunity. And therefore, any interventions that are applied at this stage are considered sort of therapies to treat the diabetes and not preventive strategies. So anything that is applied at stage 1 or stage 2 is considered an intervention strategy. Once the individual goes on to clinical diabetes, which is stage 3, then all we're attempting is trying to preserve the residual beta cell mass. And finally, when we go on to stage 4 diabetes, that's when we're only attempting to sort of replace the beta cells that have already been lost. So again, just talking about stage 1 and stage 2, which is the stage of development of autoimmunity. And stage 2 is where dysglycemia already has developed, but the individual has still not clinically presented with diabetes. So any immunotherapeutic approaches that are applied at this stage are basically attempting to prevent progression from this autoimmunity stage onto overt clinical diabetes. And this is, as I said, considered now a treatment of early diabetes, because we know that individuals who are already at stage 1, that is, they have more than equal to 2 autoantibodies, will almost inevitably, all of them go on to develop eventual diabetes. Stage 3 trials usually enroll individuals who are very early on in their diagnostic process, that is usually within 100 days of diagnosis, and we're trying to preserve whatever residual beta cell mass they have, because we know that even at the presentation of clinical diabetes, many individuals can still persist to have significant functional beta cell mass. So when we talk about, rather before going on to talk about potential interventions, it's always good to sort of go over the immunopathogenesis of diabetes so that we know what are the individual points at which immunotherapeutic interventions can be applied. So we know that there's an initial phase or wave of beta cell death, which leads to release of islet autoantigens. These are then picked up by antigen presenting cells such as macrophages and dendritic cells. which are then presented in an HLA-dependent manner to T cells, leading to their activation, which then infiltrate into the islets and lead to a further wave of beta cell death. And similarly, there is activation of many other immune cells, which lead to immunofiltration of the islets. So immunotherapeutic interventions can be applied at all of these steps or stages, inhibiting the activation of any of these immune cells, and finally, basically in an attempt to try and prevent insulitis and beta cell death. So you can have antigen specific approaches, and the sort of rationale here is that you try to induce a state of immune tolerance by constant exposure by a low dose of an antigen. On these antigens are basically GAD and DIPEP, which are islet autoantigens basically, or non-antigen specific approaches, which are just trying to inhibit immune activation of all of these immune cells which infiltrate the pancreas in type 1 diabetes. So it can include anti-CD3 antibodies, CTLA4 immunoglobulins, both of which basically act to damp down T cell activation. Anti-CD20, which is, we know, rituximab, a B cell inhibitor, or anti-cytokines such as anti-TNF and anti-interleukin 1. And I'm going to talk a bit more about these in the coming few slides. So as I said, there's a huge sort of arsenal of immunotherapy for type 1 diabetes, and we can sort of go on talking about this for ages and ages, but I'm just going to focus on a few important ones which have shown some very positive result in the last few years. And lymphocyte targeting is where most of the recent interest has focused on, and here too particularly anti-CD3 antibodies and CTLA4 immunoglobulins, as I said, both of which act to inhibit T cell activation, so which will then basically work to reduce beta cell death by T cells. Anti-inflammatory drugs. The other thing is targeting antigen presentation. This was, so GAD, alum, and pro-insulin peptide was used quite a bit in immunotherapeutic trials in the early 2000s. They haven't really shown too much therapeutic promise, so not a lot of work recently being done in this area. Targeting antigen presenting cells such as B cells by rituximab. Again, this has shown some positive results, and then blockage of HLA class 2, which will basically block T cell activation. And then another interesting area which has sort of come into this arena of immunotherapy, not exactly immunotherapy, but works along with immunotherapy, is trying to support the beta cell at the same time as preventing immune activation against the beta cells, because there's now more and more data coming out that it's not only immune destruction of the beta cells which is important in the pathogenesis of type 1 diabetes, but the beta cell itself may have some limitations itself. So using drugs like GLP-1 agonists, hydroxychloroquine, and metformin may help in this instance. And then finally, cell-based therapies, which again I'll talk about a bit more in the coming few slides. So I'm not going to talk about all of these because I said we can keep talking about it for ages. I'm just going to focus on two important ones. So one is, I'm sure all of us know about this because it created such a positive hype when it came out, and deservedly so. This is anti-CD3 or teplizumab, and this was a study conducted through the TrialNet network in individuals at risk for type 1 diabetes. So this was people who were at stage 2 diabetes, again reminding everybody they were 2 or more antibody positive and had evidence of dysglycemia. And you can see here the hazard plot here on the right hand side with the teplizumab group. This was an RCT, obviously, the teplizumab group in blue and the control or placebo group in red. And you can clearly see here that the teplizumab group persisted to be free of diabetes for longer as compared to placebo, and the drug delayed the onset of diabetes by 24 months, so 2 years in the treatment group. But the key thing again to take away from this slide is that the drug only delayed the onset of disease. It did not prevent the onset of disease. So it was a halting process. It was not an abolishment process. And then more recently, this was published last year, again in the NEJM, which was the use of golimumab, which is an anti-TNF alpha inhibitor. Again, the rationale comes from use in other autoimmune conditions such as systemic sclerosis and ulcerative colitis in adults, where it basically acts to inhibit immune activation by inhibiting cytokine function. And again, in this study, they randomized young individuals with newly diagnosed diabetes, so within 100 days of diagnosis. And at the end of 52 weeks of the therapy, they did a mixed meal tolerance test, and they studied the C-peptide, and they found that the area under curve of C-peptide was higher in the treatment group as compared to the placebo group, and also insulin use was lower. So again, not fantastic results, I would say, but something positive certainly. So these are all the stage 3 prevention trials that have been successful, and have been done over the last maybe 10 or 20 years. Again, teplizumab, which is anti-CD3, rituximab, which is anti-CD20 or anti-B cell, abatacept, which is a CTLA4 immunoglobulin, again anti-T cell, and anti-thymocyte globulin. All of these have shown some positive results, but again, key to read and key to remember in all of these trials is that there was mainly just a delay in decline, and that too of C-peptide. So these might just have been statistically significant results, but what they translated to in terms of clinical improvement and in the long term in terms of prevention of complications and holding the individual tight with a good glycemic control, we're not 100% sure of that just yet. Now, in the final sort of armamentarium that we have in the immunotherapeutic area is the use of cell-based therapy, which can be with the use of cord blood, dendritic cells, T regulatory cells. Again, those I'm not going to talk about. I'll focus on the stem cells here. So the hematopoietic stem cells, where again, the rationale basically is like a bone marrow transplant, where you're trying to reset or rejig the immune system to get back a state of immunological tolerance and prevent further attack or autoimmune attack against the beta cells. And I'm sure, again, all of us have read this paper, which came out from Julio Voltarelli's group and was published in JAMA now about 12 years back. And this is, must be remembered, this is the only stem cell based therapy which has yet been shown to be effective. And at about 3 years post the HSC transfusion, about 50% of individuals still manage to retain long-term insulin independence. So this is the only cell therapy which has worked. But importantly, and a key thing to remember is that there were significant side effects associated with this therapy. And about 40% of these patients went on to develop oligospermia and to develop nosocomial pneumonia. So not small, big, major side effects. And therefore, this has still not come into the arena of regular clinical therapeutics for type 1 diabetes. It seems to work, but for how long? And this was just a 30-month follow-up data. Whether this would be lifelong independence is unlikely. So we're not sure what the long-term results are, and there are significant risks associated with the myelosuppression. Then coming on to mesenchymal stem cells, which again have more immunomodulatory functions and basically damp down the autoimmune attack against beta cells. And not a lot of results in this arena, maybe 2 or 3 studies, mainly in human beings, lot of preclinical and animal data, but in humans, not a lot of studies. This was one of the biggest studies and the most important studies published by Oral Kortsson's group from Sweden about 6 years ago, where this was a randomized controlled trial with 20 adults with new onset type 1 diabetes. And again, they gave one infusion of, I believe, bone marrow derived mesenchymal stem cells. And at a 1-year follow-up, when they did a mixed meal tolerance stimulated C-peptide, they found that while in the control group or the placebo group, the C-peptide levels as expected fell because as expected, beta cell function declined over time. But they were preserved in the treatment group. And very importantly, there were no side effects of this treatment. So it was a safe treatment. So again, sort of just proving that there are some probable positive effects of mesenchymal stem cells, but whether it can work in isolation just by itself to treat type 1 diabetes, I'm not quite sure. So again, coming on to sort of the key point here, all of this work, so much work over so long, what is the end point? Are we really succeeding? Are we towards a cure yet? So what has been, if you look back over all of these studies that I've just presented to you, what all of these studies are basically showing is that there's basically a delay in the fall of insulin secretion. So what these immunotherapeutic approaches are doing is that they are halting temporarily the process of beta cell destruction, but they're not sort of abolishing it. So well, in the control group, the beta cell function continues to decline. In the treatment group, it sort of holds stable for about 6 to 12 months. And then after that, once the effect of the drug wears off, there is a similar or a parallel decline in C-peptide or beta cell function, which is seen even in the treatment groups. So these sort of results have taught researchers a lot of things, and people are now coming out with these potential solutions. One thing is that I think we're coming to terms with the fact that one drug is not going to do the trick. We're probably going to need combination therapy. So we're going to have to, just like in other autoimmune diseases where often one drug does not work, particularly in the induction phase, we need maybe a multi-pronged approach to try and sort of hit it hard at multiple areas. So try to sort of approach the autoimmune process from multiple areas. The second, again, important thing, just like other autoimmune diseases, is that one time therapy is not going to work. Probably we're going to have to need some sort of continuation phase of this therapy, so as to sort of keep the autoimmune process inhibited. And then finally, and very importantly, which is true of all immunotherapeutics in type 1 diabetes, is that we're going to have to hit it early, because we want to start at this phase where significant amount of beta cell function still remains. And then coming on to the area which is the treatment phase, which is beta cell replacement, again, an area of intense research focus and interest, particularly from patient and advocacy groups. And we know that beta cell replacement works because of the experience from pancreatic and islet transplantation, which has been shown to work for many, many years now. But we know that transplantation is easier said than done, and there is limitation of donors, limitation of organs, and then finally lifelong immunosuppression, which is needed to prevent autoimmune attack against these pancreas. There are a lot of approaches that are being tried in the beta cell replacement arena as well. But most of them are preclinical at this stage, so I'll not spend a lot of time on them at all. But just for your interest, these are sort of chimeras that are being developed now, again in preclinical stages, where the rationale or the thought process is that you can have an organism which is a chimeric organism, so it has cells from two different organisms. So you could theoretically grow a human pancreas in for example, a pig. And then these could be used as replacement organs for human beings, but very much in the preclinical arena. Then is the second sort of modality, which is transdifferentiation, which is basically a process by which endocrine interpancreatic non-beta cells or extrapancreatic non-beta cells can be differentiated into beta cells. But again, I'm not going to focus on this area. So I'm mainly going to talk about the use of pluripotent stem cells to regenerate or recreate fresh or new beta cells to replace the ones that have been lost in type 1 diabetes. And particularly in the last week or so, the focus on this area has doubled, tripled, quadrupled, I would say, because of this news item that came out recently, which was that a gentleman with type 1 diabetes for many, many years has been treated with an infusion of stem cells, stem cell derived islets, and he has become insulin free. And because of that, the research focus has intensified in these areas. So basically, what is the theory behind the use of pluripotent stem cells is that pluripotent stem cells have the ability to derive any kind of adult cell in the body. And what is basically done here is that we're trying to recapitulate human organogenesis, but in an in vitro system. So you take pluripotent stem cells, and a combination of growth factors is used to guide differentiation of these pluripotent stem cells to adult beta cells. But again, easier said than done. Otherwise, this would have been working very, very long ago. We know that there are a lot of roadblocks still in stem cell therapy for diabetes. The first and the most important one being that these cells have to work. They have to secrete insulin in response to glucose. And finally, also, they have to respond to a high glucose as well as to a low and a normal glucose. So that is being handled by improving the differentiation efficacy and better protocols. And that's almost sort of work now. There are very good protocols in system now which have derived beta cells which are glucose responsive. But the other aspect is a bit more challenging. We know that beta cells do not exist in isolation by themselves. They need the sort of supporting framework of a lot of other non-beta cells, such as alpha cells, delta cells, and there's a lot of endothelial cells. They need blood supply, they need a framework, and also exocrine cells along with them as well. So what people are now trying to do is they're trying to create organoids of the islets, and they're trying to create 3D islets so that it can be a crosstalk between endocrine and non-endocrine cells. The other major issue is that we know that these islets are still going to be prone to the same autoimmune attack with the individual's native islets were. So we need to protect them against immune attack. And then finally, there's that risk of safety, because we know that these came from pluripotent stem cells, which have a risk of teratoma formation. So what people are doing now to address these issues, the most important one, as I said, being the immunomodulation issue, that is these cells are still prone to the immune attack.
Sorry,
So
Dr. Kriti, sorry to bother. If you could wrap up now, next, say,
okay.
1 to 2 minutes. Yeah.
Okay, I'm just at my last 2 slides, I think. So what people are now doing is they are encapsulating these islets in sort of a semi-permeable membrane, which allows the nutritional inputs to come in and the insulin to come out. So that's one therapy. And then people are trying to create immune privileged pluripotent stem cells, which have knocked out HLA so that they can't be recognized by the immune system, which express programmed death ligands, which can switch off T cells, and which have a suicide switch included in them, so that you can sort of basically kill the cell, so that if there is any teratoma formation, the graft can also be killed. So just to summarize, beta cell preservation remains a work in progress. It's still challenging, and we need to understand the disease better to design better future trials. Particularly so, we need some long-term efficacious treatments, and that will probably mean that we'll need to use chronic therapies and combination therapies rather than a single agent and a one-time agent. Stem cell therapy definitely is the future of type 1 diabetes, but the main issue which we're going to have to address is how to address the immune attack against the beta cells. So with that, I'll end. And again, thank you to the organizers. Thank you to Rakesh sir for this opportunity. If there's any questions, I'm happy to take them. Thank you.
So I can't see any questions in the chat box. Just a small comment if time permits. So we at our center also try to do something on this topic, actually. Small pilot studies. We actually gave very high strength probiotics in new onset type 1 diabetes. We all know that gut microbiome and dysbiosis in the gut and the local immune mechanisms which are altered in patients with new diagnosis of type 1 diabetes. So gut microbiota is supposed to have some role in etiopathogenesis of type 1 diabetes. So we try to intervene at that stage in newly diagnosed patients, obviously. Special probiotic, it was actually costly as well. So VSL3, it comes as a very high strength. It's normally, say, around 10 times the normal probiotics which are available, the strength of those probiotics. So there were some, again, the results were similar. C-peptide being preserved over, say, 6 months or so. We had 6 months follow-up for those patients. And some trend towards a better glycemic control. That was obviously one of our clinical outcome parameter. So it was recently published in Pediatric Diabetes. If someone is interested, can go through it. So there are some minor things. Maybe we now plan to have some bigger trial on this. So yeah. So any other comments, questions from the panelists? Otherwise, yeah, Dr. Monica.
Vandana Jain ma'am has asked to Dr. Kriti that are there any ongoing trials of stem cell therapy for diabetes in India?
Ma'am, not that I'm aware of for type 1 diabetes, because as such, if you talk about stem cell trials for type 1 diabetes, I think there are only a couple of companies overall in the world who are doing clinical trials right now. One is ViaCyte, which is working on pancreatic progenitors, and one is Vertex Pharmaceuticals, which is the one that was recently came into the news of that 64-year-old gentleman who was treated with type 1 diabetes, and they are using the Harvard Stem Cell Group's protocol-derived islets for type 1 diabetes. So as far as I'm aware, those two trials are basically being run out of the US. I think Rakesh sir can correct me if I'm wrong, but there were type 2 diabetes trials of, I think, MSCs and HSCs, which were done in PGI Chandigarh, but those were in type 2 diabetes, not in type 1 diabetes. And replacement trials of using pluripotent stem cells, I'm not aware of anything being done in India.
So yeah, if I can add to that, there are no obviously trials in India, but there are few centers who are performing stem cell therapy for type 1 diabetes as well, although I would say illegally. So there is a center in Gujarat. There are some publications as well from them. So it's a private center in Gujarat. I'm not remembering the name of the authors right now, but they have done work on this, and they have reported few adults with type 1 diabetes, and they have done just few cases they have actually done and reported the results as well. So
That's
in PGI, it was
hematopoietic stem cells or
yeah,
mesenchymal stem cells, and not pluripotent stem cells.
yeah. So and yeah, that's it. So PGI, you have already mentioned it was type 2, and even in type 2, those who were on 2-3 oral hypoglycemic agents plus insulin, very poorly controlled type 2s.
Yeah.
So even in them, they did not see good results, and they actually stopped that, obviously.
Yeah.